Hi there. My name is Tim Nichols. I'm an optometrist in Alabama. 2020 was a difficult year. Thank goodness now in the spring of 2021 we're in a little different place. But still, there are some things that happened in 2020 I think that will have lasting impact on our practices forever. We had, like you, a lot of uncertainty that took place when we were uncertain, first of all, how a person got the virus. Could you get it from handling a gas pump, or uh, how transmissible was it? How virulent was the virus? What was the morbidity going to be? All of those things that led to the shutdown and really caused us to question the future of our businesses in general. We were in a position where we had to reopen with certain stipulations, probably a lot like you. And we had a 3 doctor practice. 2 of us would work on any given day. And we had to then make physical changes, all the barriers and the PPE and so forth. The CDC recommendations we were trying to follow. It appeared that 15 minutes of contact time was probably the magic number. If you could minimize that, then that was going to be important. And taking all of that into account, how do you take a 64 hours of appointment time and condense that so that the doctors would be able to still maintain production, but we could space our patients out? Well, we looked at all kinds of different ideas, but we pretty much came up with, let's just work 4 10-hour days, 1 doctor at a time, and try to keep our contact time with each person that was going to be seeing the doctor, whether it was a technician or the doctor or a scribe or whoever, less than 15 minutes, and stay focused on the values that we have as a practice, that is the quality of the experience, and try to maintain the safety that the patients were needing and expecting at the same time. So this was an experiment. We didn't know if it was going to work or not. And surprisingly, it did. I was very skeptical. You go to a CE meeting and you talk to some guy in the hall and say, well, how many patients do you see there? Well, I see 40 patients a day. And you think, yeah, you schlock. What are you just running them through like cattle or something? I can't do that in my practice because we focus on quality. Well, I tell you, when COVID forced efficiency on us that we had not previously been practicing, I learned that it was indeed possible to see 35, 40 patients a day, maintain good quality experience on both the patient's part and the doctor's part. And here's why that worked for us. We were seeing really the same number of people a day. The same number of staff were working every day. The same number of people were coming in, but instead of 2 doctors seeing those patients and taking our staff and dividing half the staff to give to this doctor and half the staff to give to that doctor and serve them, we took all the staff and said, you're going to serve that 1 doctor at a time. And that the only 2 people really then seeing more people per day in a situation like that are the doctor and the scribe. And that can be very easy if you kind of grease the skids and make that possible. So the real preparation that you need to do to be able to take that step and do this is realize that the choke point and the slow point in all this is quite often has to do with the electronic record and charting, trying to get all of that information into the chart and get an accurate and a good chart detailed properly just takes time. So there are several things that we were able to do in preparation, and we didn't really realize that we were doing them in preparation for a pandemic, but we had been doing them all along. And that is in the chart, our EHR system uses what's called FAST plans. And a FAST plan is a customized, detailed plan that includes everything from what you're discussing with the patient, the orders, the letters, the recalls, all of those things for the most common conditions that you encounter on a day-to-day basis. So you spend the time in advance to actually create those. And then with a few simple clicks, you can uh, end up a visit, and it'll have everything in there that you need. The other thing that's important, I think, is that your system be able to manage images so that in the chart with the INR there, you're not jumping out of software here and there to review images that are taken and so forth. You're able to see them all in the chart and they're stored there. All of that kind of thing was done for us in advance. So when we decided to take this step, this experiment that we were doing with one doctor at a time, the charts were already, our charting methods were already pretty much in place. The other thing that we did was that we said, all right, if we're going to see these people, we have to know why we're seeing them, what's going to take place, who's going to do it, and everything in advance. So the charts have to be prepped before the patient gets there. Insurance needs to be verified before the patient gets there. You need to know what they're eligible for, whether this is going to be a medical visit, whether it's going to be a vision-related visit, and if they have benefits that are going to justify you spending that whatever time you're going to do with it. So make sure that you've got the insurance verified in advance, and that the text then will take that chart, pre-fill it with previous information from the charts. So if you know there's a nevus, for example, and you're going to need to be looking at that today, that's already there. You're documenting it, you're looking at it, you're verifying it. All of those things are looked at. Obviously, this takes a lot of training, and training your techs and your scribes is very, very important. Technicians have to understand how to do their job, how to do it well, and how to do it in 15 minutes, because that's all you've got. And not only that, now they have to be able to clean rooms thoroughly after the patient leaves. We had a checklist, a little card we printed up and laminated it, and on the back it said, clean the phoropter with this, clean the tonometers with this, clean this, clean this, clean. This is how it's cleaned. You've got the checklist. On the reverse side, it said room sanitized. So when a patient walks into the room, first thing that they see the technician do is remove that room sanitized thing out of the chair and place it over on the counter. And when the patient's done, the technician goes back and uses that checklist to make sure that the room is cleaned. So that's part of the technician's job as well. But the real key in all of this working, I think for us, has been the 100% use of a scribe. Now, up until that time, we had used scribes, but a scribe was also a technician. Now, our scribes are technicians, but not all of our technicians are scribes. And if you're a scribe that day, that's all you're doing. You stay sewed to the doctor's hip, and you help the doctor out. And so you understand that a scribe is really not an entry-level job. Some doctors I've talked to that say, well, I tried to scribe and then it just didn't work out because I was spending so much time trying to tell them what to enter into the chart. Your scribe needs to know what you're going to think before you even think it. The scribe needs to be able to transfer your conversation with a patient into the chart narrative. You don't need to tell the scribe, write this down, write that down, write this word. No, you need to be just conversing with the patient in a normal fashion, in a very relaxed fashion, and the scribe has to understand enough of what you do on a day-to-day basis to be able to extract that information out and get it into the chart. Our scribes also do our coding for us, so they have to understand the difference in vision exams and medical exams. They have to understand that there has to be a connection between the chief complaint and the plan. The scribe has to understand the levels of E&M type coding. The scribe has to understand all of these things and code appropriately for the doctor. We have safety nets after that, by the way, in which we'll review all of those things, but the scribe is the one who's actually entering the charges into the chart. So you understand then that not all techs are scribes. You really need to have that super person prepared to be your scribe and a backup as well, because as you know, not everybody's going to be there every day. So the other thing I think that made this work, in addition to the preparation, in addition to the things we've done with our EHR, the things we've done with our scribes and training and so forth, was that you have to maintain a positive environment. You have to be the leader. You have to The sky is not falling. There will be a tomorrow. There are going to be lots of people out there. Most all of them have two eyes and they need some sort of care. So you're going to be the guy that does that. We're going to be the office that does that. And we're going to do a great job. We may have to alter our methods somewhat, but we will do this and we will get through. So the doctor's leadership is the key. The practice owner's leadership is the key. But you have to encourage the office staff. And it was wonderful to see that how they had each other's back. Sure, we had people that were out. We had people that were out with COVID. And so we had people who were out with family members. And during all of this time and you're short staffed, it was really refreshing to see the folks in optical say, hey, we'll help clean the rooms. Office manager says, hey, I'll help clean the rooms. Keep you technicians rolling and moving fast as they needed to. So what we found in all of this experiment was that, number one, our patient satisfaction was consistent. Our Google reviews, our 5-star Google reviews just kept building and building and building. Patients, by the way, don't equate the quality of the experience with the time spent in the office. Get that out of your head. If anything's true, the inverse is true. They have in their minds about an hour that they're going to be in that office or less, and if you drag it out too long, you've actually hurt their experience rather than helped it. So being efficient enough to get them in, get them taken care of, get them out was really meeting their expectations and helping them out. And the second thing we found is that our staff really loved a 4-day week. It turns out that they didn't want to go back. They don't want to go back. They would rather come in early and stay a little later and have that Friday off. That was a big win. And it was great to see people rise to the top. When you ask folks to stretch themselves a little bit, there were some people that we thought were going to be great scribes. No, they didn't really want to do that. They're really excellent technicians and do a great job at that. There are people that were technicians we didn't think would be great scribes, came up and they grew in that role. So what I learned from COVID, what I learned in 2020 is that nobody wants change. I certainly didn't want change. You can tell I'm not a spring chicken, and I don't want to do anything different tomorrow that I haven't been doing yesterday. I don't want to try to learn anything different. But even old dogs like me can learn new tricks when they're forced on you, and I wish I had done it years ago. Hope that helps. Thanks.